Hello, my name is Dr. Edgar Tay from the Asian Heart and Vascular Centre of Singapore. Today I'm delighted to speak to you on this topic on COVID and the heart, especially about the long-term impacts on the cardiovascular system. So COVID is a very heterogeneous condition. When you talk about the heart, it can present with very asymptomatic disease, but it can also present with very severe presentations or phenotypes, for example, acute heart failure, acute myocardial infarction, or even cardiogenic shock. What I want to actually emphasize is that actually if you look at the amount of data that we have, a lot of it is focused on the orange box. But if you look at the majority of patients, they actually fall into the asymptomatic or mild presentation. And we have very little data on this particular group of patients. So really today we're going to explore and try to decipher whether at the end of COVID-19, will all our patients be running and be back to normal? Or will we be burdened with a long-term sequelae of cardiovascular diseases? So before that, let's go through a little bit about COVID and how its impact on the heart is known at the present time. So if you look at this very early set of data, we know that patients that present to the hospital with COVID-19 infections actually have cardiovascular impact. And you can see that at least 50% of these patients will have elevations in their troponin level. There has been postulations on how these mechanisms can occur, and this can go through a process of type 1 myocardial infarction, type 2 MI, or even things like chronic ischemia, stress-induced cardiomyopathy. And these are the typical phenotypes that we have kind of explored or postulated. It has only been pretty recent that imaging has proven that these speculations were correct, in that a significant proportion of patients may present with myocardial injury from myocarditis, some with combinations of ischemic heart disease with myocarditis, and some with ischemic heart disease alone. There are also very unique presentations that have been described. For example, this is known as stress cardiomyopathy or Takotsubo cardiomyopathy. This is really a condition where the patient is under significant stress from an infection and then develops a weakening of the heart muscle. And it's very unique, called Takotsubo, because it looks like the octopus trap that the Japanese fishermen used to trap the octopus. So you can actually see that the shape of the heart resembles this structure. If you look at the epidemiology, there has been a significant increase in the number of cases of patients with stress cardiomyopathy. Arrhythmias is also a very prominent feature. This is firstly described in the early experience from the Chinese, and up to about 7-8% of patients would have significant arrhythmias, including things like atrial fibrillation, PVCs, atrial ectopics, or more serious conditions like VF or VT. Acute TC prolongation is something that we see as well, and this typically is related most times to the drugs that we give to patients with COVID-19. Acute myocardial infarction you're all familiar with. There was a bit of a scare initially, thinking that a lot of patients with COVID-19 may present with acute myocardial infarction. Yes, there is a signal that the risk is higher. If you look at this data, those between 0 to 7 and those between 8 to 14 days after COVID-19 have a significant risk of developing acute myocardial infarction with COVID-19. But the actual numbers are not that high. Heart failure is also common. If you see patients with COVID-19, if they have pre-existing heart disease, especially if a history of heart failure before, their prognosis is poorer. They are at higher risk of going to the ICU or even having higher risk of mortality. Some can present also with right heart failure, especially those with extensive lung disease or what we call ARDS, or acute PEs that can lead to right heart failure. Some patients may crash and present to us in cardiogenic shock. And there's also another interesting condition that presents like heart failure called the MISA, or multi-system inflammatory syndrome in adults. This is a unique condition typically seen more in the young patients, middle age. They present with fever, some gastrointestinal symptoms, and then they can present suddenly very sick with low blood pressure, poor ejection fraction, and inflammatory markers all being elevated. This is actually a unique subset of patients, but again, not a lot of patients present so sick like this. Venous thromboembolism is something that we have also seen in patients with acute COVID, and these hospitalized patients have a much higher risk of developing clots, say, in their legs, like DVT, or present with acute pulmonary embolism. But this is really the kind of patients that present very dramatically, and you can actually see this classic phenotypes, and we know all the sort of sequelae that follows these conditions. But what we're really interested in today is actually the more common group of patients that we don't really know a lot about. And this is the patients who are less symptomatic and the ones that didn't get into hospital. What actually happens to these patients? Do we have data on them? So this is where we want to discuss this condition called the long COVID syndrome. And basically, these are patients who have had COVID, they didn't die, they didn't have very severe disease, and they recovered. And 4 weeks later, they continue to have symptoms which have become a problem for some of them because it affects their quality of life. And so we know that cardiovascular symptoms are very common after what we call recovered COVID patients. So if you look at most studies, dyspnea and chest pain is a pretty common presentation. Some also present with palpitations. And in this particular study, you will see that patients who were hospitalized or had a more significant kind of post-COVID inflammation state actually had more higher risk of developing long COVID cardiovascular symptoms. In fact, patients who are older, females especially, and those with higher body mass index may also have an increased risk of developing cardiovascular long COVID symptoms. And especially those who had to present with a lot more symptoms in the acute phase, they are also more likely to get the long COVID symptoms. As cardiovascular specialists and also primary care specialists, we need to really look at the patient as a whole. We need to also understand that during this pandemic, what has really happened is the patients, some of them have actually neglected also their ability to see the doctors because of the fear of getting to a hospital. So their pre-existing cardiovascular risk may not be well managed. So you need to look at also the other things that can contribute to some of these symptoms, not just COVID, but actually a worsening of their pre-existing cardiovascular problems. But we also have to understand that COVID may have an impact on them. For example, can impact on inflammation of the blood vessels, impact on the risk of thrombus formation. So we need to look at the patient as a whole. We know from basic science that there is actually a lot of significant injury in the microscopic state. And if you look at the cells itself, you can have direct viral damage to the cells. We also know now that actually the virus can actually result in some immune-mediated response that can influence also the autonomic function and lead to autonomic dysfunction. And if there is also fibrosis that occurs at the level of the cells, increased fibroblasts can actually cause this displacement of desmosomal proteins and over time increase the risk of patients getting palpitations or arrhythmias. So in this group of patients, what do we do with them? There is actually some data or some guidance from the athletes, young people who have had COVID and what to do. Can they go back to sports? So in the patients who are very sick, hospitalized and very, very ill, there's a very clear pathway and well described that we should really assess them, make sure that they are safe, their troponins have to be normal, their EF has to be normal before they can go back to their sports. And typically that will be a 3 to 6 months period before they can actively go back into sports. So we have a well-defined guideline for this group of patients. But what I want to highlight is really the lack of data in the younger cohort or the well cohort who didn't go to the hospital, didn't present so sick. This area of patients, the data is very, very lacking. So if you look at this Frankfurt study, 100 people recovered. They just randomly took this group of patients about 71 days after their COVID infections. They just brought them in, did an MRI scans, did some blood tests, and they found that a lot of them actually have MRI abnormalities still at 71 days, and their troponin levels, which is a marker of myocardial cell injury, is still elevated. And in a young group of patients that they just selected, about 23 of them, when they came in, they just did an MRI for them. They didn't have any symptoms. They looked like 15% of them actually met criteria for myocarditis. So the actual virus can affect the heart without the symptoms, and these athletes don't even know about them. So 15% was really a little bit of a shock to the community. So subsequent to that, they did a much larger study. So they're looking at 10,000 athletes now. And actually, when they zoom down to actually how many athletes actually can get this kind of myocarditis, is actually about 2.3%. So not as large as we thought it would be. But what was interesting in this group of study, the athletes were then subsequently followed up and they did the MRIs again after a certain period of time. And you can see that the patients who were actually more symptomatic with the myocarditis presentation tend to have less recovery. And you could still see damage on the MRI. But the patients who are subclinical and really have very little symptoms, a larger proportion of them actually improved. And this is a reassuring set of data. This is probably the latest set of data that actually looked at 6 months later after COVID, comparing a group of patients that had COVID and a group of patients that didn't, and look at the MRI. And actually, in this particular study, the MRIs look fairly identical. So there could be still ongoing kind of early damage, but over time, there could be also recovery. POTS is a unique situation where patients present post-COVID with palpitations, and this typically occurs when a patient stands up, what we call postural orthostatic tachycardia. And this is a unique situation where patients feel very symptomatic when they get out, when they stand up, or sometimes when they do a little bit of work. And so what we have now done is that look at these patients. There is a registry going on to study these patients, and we found that certain medications like Corolan, beta blockers actually help these patients. But what about the long term? What happens to them over the long term? We really have very little data, but here is where we try to gaze through the crystal ball to try to guess. So number one, we know that troponin elevation in a variety of conditions, not just cardiovascular AMI, even sepsis, can raise troponin. And we know that in many studies, as long as troponin is raised, the patient's long-term prognosis is not as good as those who are not. Second thing is that we know that in patients who have previous viral myocarditis before, if their MRI shows abnormality, then the risk of long-term sudden events, for example, cardiac death or arrhythmias, becomes significantly higher. So if the patient gets an MRI and has scar, for example, in the heart, then certainly their prognosis may not be as good as those who don't have a scar in the heart. There's also this concept of thrombus formation in the lungs as well, and this may have a long-term sequelae. This is a study done by one of my good friends in the university, and actually in this NUS, and it found that significant proportion of patients may have thrombosis in the lung arteries, and over time we worry that they could develop into a chronic state, what we call chronic thromboembolic pulmonary hypertension. And in this condition, what actually happens is the patient becomes breathless after recovering from an acute episode. So this is something we are keeping our eyes open. And of course, finally, if the lungs are damaged, the right heart always has to pump across a higher pressure. And over time, we also worry a little bit whether there will be an increased risk of right heart failure or right heart dysfunction. Atrial fib is also a concern. We know that in patients previously who have influenza infections, for example, can have atrial myocarditis. And in those conditions, they increase their rate of atrial fib. Fortunately, so far the data suggests that maybe the incidence of AF is not so high. In this 4-week post-COVID recovery patients, the incidence was only about 1%. So maybe not so high at this stage, but what about longer term? This is really something we are looking at as well. And this is my final slide. This actually looks at a very interesting set of data, 150,000 patients from the Veterans Healthcare System. This is really one of the largest group of patients that we have collected data on. So 150,000 patients with COVID-19 from 30 days after COVID to about 1 year at the end, and look and compare them with the historical cohort of patients who have no COVID before. And they actually seen that actually if you look at these patients, especially those who had been sicker, those who have been hospitalized, and those who have entered ICU, they have very much higher risk of developing things like acute myocardial infarction, arrhythmias, strokes. So in this case, for example, the risk of acute coronary syndrome, the hazard ratio is increased to 1.48 in these patients. So this is actually an early insight into the possible high amount of cardiovascular burden in this group of patients. So I'd like to conclude. COVID-19 infection can result in a myriad of acute cardiovascular presentations. The post-COVID-19 cardiovascular outcomes are increasingly reported, but this is just really intermediate term data. Longer term data is still coming on. We still need to follow up these patients before we can know more. But certainly, we are looking through this crystal ball, and there's already early insights that perhaps some increase in cardiovascular burden may be there. And finally, if we do detect myocardial injury in our patients, we have to be a little bit more careful with them, because we know that if there's late gadolinium enhancement, for example, or scarring in the heart, for example, then you really have to think about and discuss with the patients about what is the risk of going further into exercise, for example, and how they have to manage their lives subsequently. So with that, thank you very much.